Okay, good evening. I'll start again. Good evening, everyone, and welcome. And thanks for joining us. This is webinar number 7 of our free series for 2021. And I've got a guy that I've been trying to get in for ages now, probably a few years, Justin. I've been badgering you to do something. So managed to get you in. Justin I've known for quite a few years because he's a nutritional therapist, but he's also an academic. So he bridges very nicely between the applied aspects of nutritional information and at the same time being able to study it in scientific detail. So that I really respect about his work. A big he obviously researches quite a few different things, but through his personal experience of endurance sport, I know gut health is something of a lot of interest to him. And that's something, when I started studying this area a number of years ago, there just wasn't many texts on gut health in sport. But now there's actually quite a lot of academic knowledge. So Justin's going to go through and share academic research with you tonight, including his own research. And he's going to, well, the remit I gave him was applied practice. So if I get the chance as well, I'll jump in and give some experiential kind of input as well at certain times. As usual, we'll run this for sort of 45 minutes. Any questions you've got, just type them in the chat box. If there's any cracking questions, I'll jump in and ask him when he's in the presentation. If not, we'll keep it to later. After that 45 minutes, I'm just going to share 5 minutes on the new course that we're running at the end of this month, and then we'll go into Q&A time. So just to kick us off, as Justin gets started here, if you can type in the chat box where you're from, what you do, and what you'd like to learn in tonight's webinar. Okay, Justin, over to you.
Great. First and foremost, thanks, Ian. Can you hear me okay, by the way? Great. I was going to move it to the next slide just to check that the slides are actually moving forward. Can you see a slide that says exercise in the gut okay? Brilliant. Okay, so welcome everyone. I'm surprised we're not doing this outside, considering it's a lovely hot day outside and I'm stuck inside as usual. So for those that don't know me, I've just looked through the participant list. There's quite a few that I recognise name-wise. And so my job tonight is to firstly just welcome you, but also to talk a little bit about exercise in the gut. Now I've got lots of slides, I've got lots of information. I've got about 45 minutes, so I'll do my best. But if there's any information that we don't get onto, or there's some slides we don't cover, don't worry, you're going to get all the slides anyhow. So just a very quick introduction to me. As you can see, I'm based up at Anglia Ruskin University in Cambridge. I'm an associate professor in health and exercise nutrition. But as some of you know, I have a passion for endurance sport. I've done quite a few endurance activities myself, including various Ironman triathlons and the infamous Marathon des Sables across the Sahara Desert, where I have experienced all sorts of gut issues. So that's kind of where my interest lies. And in terms of research, one of the things that I know there's at least 2 people on the call that were involved or have been involved with some of my research. And we've done some research looking at various factors that might influence the gut from a nutritional perspective. So I hope to get onto that and share that with you. But as we go through this, I kind of want to just start by just thinking a little bit about the term gut distress or GI, gastrointestinal distress. So I should also mention that at the bottom of all my slides, I've got all the references. So if anything's cut off on your screen, don't worry. When you get the slides, you'll be able to see all the references. And for those that are not used to looking up references, literally just copy the author's surname, the journal, the year, and the volume page numbers onto Google Scholar, and it should come up okay. So you've got all of my references basically in one slide presentation. But when we think about GI distress, when you look at the literature, there's quite a broad definition of what GI distress actually is, and also who and how it affects people. So when you read some of the literature, there's a very broad range that's often quoted. 30 to 70% of athletes might experience some form of gut distress at some level. predominantly people like runners, cyclists, and weightlifters, where there's potentially impact going through the body. When we start talking about types of athletes, when we go from maybe less trained athletes up to real world-class trained athletes, the kind of prevalence of GI distress seems to go up, but interestingly enough, the severity seems to be less. So when we hear this term around varied severity of GI distress symptoms, often it's linked to the type of athlete and maybe their previous history or previous experiences. Now, why this is such a big issue, or why it's so important, or the famous "so what" question? Well, many athletes often report of impaired training, impaired performance, or impaired recovery. So this can have various effects on the body in very individualized manner, which makes it quite hard to research. The most famous case you're probably aware of is Paula Radcliffe. Dare I even go down that road? But for those of you who are endurance athletes or cyclists, or have experienced some form of GI distress yourself, you might relate it to more your training than the actual event itself. And that's quite interesting from my side of the fence. In terms of symptoms, this is a nice paper by Prado de Oliva and Professor Yerkendrop, where they talk about the types of symptoms from an upper GI and a lower GI perspective. Obviously, I'm not going to go through every single one, but I've just red flagged the kind of stomach pain as a potential upper abdominal symptom that's often quoted when I'm speaking to clients or when I'm working with participants. And within that, the concept of exercise-related transient abdominal pain, or ETAP, it often crops up in the literature. Now, when we start talking about some of these symptoms, the first thing that goes through my head when I'm reading some of these papers are, from a nutritional therapy perspective, have you done a diet history? What do you know about that person? Have you looked at their meal timing, their hydration patterns, their fluid preferences, what they're doing during training, what they're doing before training, what they're doing after training? So all of these factors have a role to play. And yet when we come to the research, often it's more focused on experiencing GI symptoms during an actual event. So it's a very kind of difficult term to put onto paper, but if we try to look at some of the symptoms that are experienced between athletes, you often hear many reporting mild to moderate symptoms. So typically more upper GI related issues like nausea, discomfort, maybe a bit of abdominal angina, through to more of the lower kind of abdominal symptoms such as urgency to go to the loo. So that's often reported, and it can be not only a single symptom, but it can be multiple symptoms in synergy. Through to more severe symptoms, and often this is what in the research text they're looking to see if there's a more severity in terms of the rating or severe symptoms in terms of the clinical manifestation. So often we see terms like ischemic bowel, so lack of blood flow to the bowel, if you like, ischemic colitis, gastritis, and even lower GI bleeding. And obviously there are various case reports of endurance athletes experiencing lower GI bleeding. If you ask me kind of, well, when do we typically see these sort of symptoms? It's really difficult, because I've seen patients who have had very sporadic symptoms around training, and often their training has been very low key in terms of time and intensity, through to more experienced athletes who are training for a marathon or cycling ultra distances, through to the very long distance events like Ironman, triathlon, where the prevalence seems to be a little bit higher. And some of my early research, we were kind of asking the question, well, is it the distance thing, or is it the intensity thing, or is it the hydration thing, or is it a combination of all of these things going on? But it seems to me that as athletes try to perform harder for longer, potentially in a dehydrated or semi-dehydrated state, this can have repercussions to how the gut actually functions. The other thing I just wanted to mention, for those that know me, I used to do a lot of triathlons myself. I'm actually trying to get back into it, and I did my first long distance event at the weekend. And one of the things that went through my head when I was preparing these slides was thinking about, often we don't hear in the literature about the patient story. Often we don't hear about what else is going on for them in the background. So I did a race, well, it's actually not weekend, just gone, the one before, where it was my first one in a few years. I was a bit nervous. I maybe didn't prepare as well as I maybe did in previous years. Maybe I didn't eat as well the night before, or even the days going into that event. And I found myself, thinking about that key point that many athletes, 30 to 70% of athletes might suffer from some form of GI distress, and thinking about that this might influence, may be influenced by the type of training they've done, or maybe the diet quality they're currently undergoing. Now, for me, I did an event recently where I hadn't really trained properly for it. I wanted to see where I was, so I did it on purpose. But it was interesting because going into that event, ignoring all the kind of rules and regulations around eating for endurance of sport, I found myself almost experiencing GI symptoms, not because I had some underlying condition, but maybe because I was a bit stressed or a bit anxious. So there's a really nice paper, if you can't see it on your slide, you'll get it on the handout, by Spiegel in 2011, that very much talks about GI distress from a clinical perspective. And when I read this paper, I kind of saw a really big overlap between some of the athletes I've worked with and their experience of GI distress from a non-clinical perspective through to more of a kind of psychosocial, psychophysiological perspective. So you could argue that I'm very unaccustomed to long distance sport right now. Maybe before I was a bit more trained. So I'm taking that into consideration. But it's interesting that when I've spoken to clients about their experience of GI distress, they've often quoted things like, well, it's a physical thing. I'm experiencing pain, whether it's very high severity pain or whether I get it quite frequently, or maybe I can predict when it's going to come on. They maybe talk about symptoms like gas or bloating, and often it's described in terms of how it looks or maybe how it feels. So people have different experiences of gas and bloating. Altered patterns of defecation, so thinking about frequency and form, and that also might give you clues as to what is going on for that person in the background. And maybe we should be looking at GI distress not from a single perspective, but a whole nutrition holistic approach to their preparations. There are also what we call foregut symptoms, so things like dysphagia, reflux, nausea, and dyspepsia that might all have background prevalence in terms of symptomology. There's also cognitions and emotions, and this is the one that I was kind of referring to, the idea that, where's your focus, where's your focus of control? Is it, are you in control, or do you feel like you're out of control? Does that have a gut-brain kind of dysregulation pattern that's going on? Are you catastrophizing in some form, whether it's your lifestyle, stress at work, stress of the event, stress of training? Is that causing anticipation anxiety? Is it causing visceral anxiety? So the fact that, for some of you who might have experienced GI symptoms where you've been on a training run, and knowing that could occur, does that create further anxiety that leads to this state of visceral anxiety? There's also the concept of what we call devitalization, or inappropriate fatigue versus actual fatigue. And for many people, this kind of feeling of being worn down and devitalized might actually provoke some of the responses we're seeing when it comes to GI distress. And maybe there's a kind of complex interaction between these various interplay here. So the reason for putting that slide up is to think about people that present with what I call longer term anxiety related GI distress patterns versus event or training acute related GI distress patterns. In terms of prevalence, this is quite interesting because there's not a huge amount of information out there in terms of how many people suffer from GI symptoms. It's very broad, but this is one paper that was published in 2015 and a follow-on study in 2016, looking at athletes taking part in an ultra marathon, the Western States Ultra Marathon. And of the 272 runners that were taking part in this particular study, it was noted that 96% of them reported some form of symptoms, and you could sort of see the frequency of those symptoms on the slide. What's obvious when you start doing long distance events, the kind of concept of nausea is most commonly reported, followed by things like belching, stomach bloating, cramps, etc. And interestingly, there seems to be this kind of nausea reduced appetite interplay. So in other words, as you start to feel a little bit more like you can't eat, or you start to feel a bit more sick, actually that starts to have an interplay between what you're doing and the body mass change that you associate with long distance events anyhow. So what that means is those people who had nausea in this event or experienced nausea, particularly in the first or second segment of the race, were more likely not to feel like they could eat, and therefore were more likely to lose weight, which we all know is associated with reduced performance. So there's kind of those sort of symptoms to think about. And this is quite an interesting point, because a few years ago I published a paper which was an international position stand paper looking at nutrition for single stage ultra marathon running. And we made some very controversial statements in there based around personal experiences and also experiences from many types of ultra runners around the idea that when you're starting to feel a bit sick, what do? Do you actually stop eating and therefore run the risk of not finishing? Or do you kind of force feed, which is kind of a bit, controversial? And the interesting thing is that when people start to feel like this, even if they don't feel like getting something in, ironically, when they do eat, however small, you seem to see this reversal in some of these symptoms, which is quite interesting. And interesting enough, within this study, when they talked about race finishers versus non-finishers, it was interesting that there was a very similar ratio between the two in terms of not only experiencing GI symptoms, but for the non-finishers, about 40% or just under, suggesting that their GI symptoms were a reason for non-completion. And in the later study by this author, they also noted there was a very individual predisposition to the types of symptoms being experienced with endurance events, and that there was a kind of correlation between certain symptoms like nausea severity and inflammatory markers from the gut, such as soluble CD14. So we know that there is potentially this association between the way the gut's responding and the secondary symptoms that people are experiencing. So if you ask me kind of what are the causes of GI complaints, I could probably sit here all night on just this slide because we could probably talk about it from a single cause versus a multi-complex model perspective. But if I had to try and break it down, I would break this down into 3 categories. I would break it down into physiological categories. So we know that when people start to exercise, very clearly, the muscles need oxygen. They need blood flow to get that oxygen. So you see this kind of reduction in blood flow away from the gut, which potentially starts to create mild going into moderate ischemia of the gut organs. So if you are exercising and not really hydrating, or you have some sort of fluid restriction regime, that can actually make your symptoms worse. And believe it or not, I've had people that haven't actually thought about that and realized that simply all they need to do is the basics: drink a little bit more water when they're exercising. We also know that when you exercise, the gut core temperature can actually reach temperatures very similar to muscle, although this has been kind of contended in the literature. There is potentiality for increased temperature causing disruption of the gut protein, tight junction proteins. This is the one that I think I experienced at the weekend. I went into a race where I was just trying to get loads of sports drinks in, thinking that's what I needed to do at the time. And actually I hadn't really trained myself for that. So I ended up with what I felt like was quite a distended stomach and starting to feel a bit nauseous. So maybe there's a kind of sense of getting the body used to it from a training perspective. The one that's most commonly reported in the literature is this idea of gut permeability, the fact that the gut lining can start to become damaged in some manner, either acutely or transiently, either during exercise or after exercise. And this might explain why some people experience symptoms during the exercise, immediately after, or several days after exercise at different levels. We know that when you suddenly stop exercise, your gut will get what we call a reperfusion of blood flow back to the gut, and that in itself can actually create further injury to the gut lining. So we almost have this kind of like starvation, reperfusion kind of cross interplay going on in the gut. And as I mentioned on the previous slide, the idea that you can also have this altered neuroendocrine function, which, if you've got the gut-brain axis being disrupted through all sorts of different mechanisms, the hormonal changes that occur can affect gut motility as well, which might explain why some people get sudden urgency. And just to sort of demonstrate that, this is one study by Van Wyck that was published in 2011, where they took a group of cyclists. And when you think about this study and you think about what a lot of people would do when they go to the gym or if they're doing their own training, this is a study where they took a group of individuals and subjected them to 60 minutes of cycling at 70% of their maximum power. So I would call this kind of moderate, maybe light, hard intensity. And what they've done on this study, believe it or not, is they've used something called gastric tonometry, which is where you put a nasal tube down into the stomach and you look at the CO2 being produced across the stomach. So this increase on your slide where it's got the PCO2, you can see the increase with exercise. This is reflective of what we call gut hypoperfusion. It demonstrates there's a lack of blood flow or reducing blood flow to the gut. And you can also see that after exercise, that blood flow normalizes, comes back down to normal. And in this particular study, they also took another marker, which was plasma intestinal fatty acid binding protein, which is a marker of, if you like, acute damage or injury to the gut wall. It's used as a kind of proxy marker of gut damage. And as you can see, when we start to starve the body, starve the gut of oxygen, we see this transient increase in this damaged protein, which then resides in a kind of delayed fashion after exercise, which might explain if someone has a very acute effect of damage to the gut wall, they might experience symptoms at the end of exercise, maybe in the first 40, 50, 60 minutes after exercise, as an example. So there's some nice science here that actually demonstrates there is direct damage to the gut wall. From a mechanical perspective, it's interesting to note that the most common symptoms are reported in runners. I wonder if this is because there's repetitive gut impact. Maybe there's more trauma or microabrasions being caused by constant movement. You do see certain symptoms, particularly things like belching and upper GI symptoms with cyclists. I wonder if that's because of the type of position they're in. Maybe they have poor core stability, which might be influencing how they're actually positioned on the bike. Maybe they're what we call air swallowing. So as they're putting the sports drink in, are they actually squeezing the bottom and creating more air going into the gut, which could be linked to some of their symptoms. But from our perspective, let's get onto the nutritional side of things. Now I could spend a whole slide just on this one quadrant here on nutritional factors. But often when you read the literature, what you hear is often people eating higher fat, fiber, protein diets during training, which could be related to gut symptoms. But you don't hear so much around pre-fueling leading to a state of gut dysbiosis. So the type of diet someone's eating might actually be quite influential. And yet that's not really, I don't see an awful lot of that in some of these studies. I also don't see an awful lot of looking at what the client's diet is leading up to the actual experiment. So I wonder how much of this is looking at the kind of whole food nature of their diet and whether it's processed or unprocessed and whether that's having a role to play. Use of anti-inflammatories, so NSAIDs, we know that can have a direct impact on gut permeability. So many athletes do use certain NSAIDs for pain relief mainly, but also anti-inflammatories. But that can also have a direct impact on the gut, which might be aggravating some of their symptoms. Again, thinking back to my experience recently compared to my experiences in years gone by, overload feeding. One of the things I try to do when I'm exercising is have a kind of pattern. So I'm trying to get a decent amount of carbohydrate into a reasonable level. But if I'm not used to the type of products I'm using, that might lead to a state of overload feeding or unaccustomed feeding, which could have a negative impact on how the gut emptying rates affect the intestinal permeability. So if you've got a very concentrated sports drink or you've not got used to it, this could have a significant role to play. So just thinking back to the science again, there are various studies that have also demonstrated not only exercise intensity leads to permeability. One of the most famous studies is by a chap called Powles, who demonstrated that when you start to exercise in the short term, if you go out for a run at say 40% of your maximum capacity versus 80% of your maximum capacity, when you start to get to that higher intensity, you see this disruption to the gut wall. We also know that if you're fluid restricted, this can also impact on permeability. So in this particular study, the authors looked at taking 20 runners, doing an hour at 70% VO2 max running. I can tell you that 60 minutes of 70% VO2 max, most good runners would find that moderately okay. So if you had a chart from say 0 to 10, where 10 is maximum effort, most good runners would start this maybe at a perceived exertion of 3. They might midway be at 5. They might finish this hour at maybe 6, 7. So for most runners, this is what I would call a moderately okay session, not necessarily severely demanding. So bear that in mind. But in this particular study, they looked at using sugar probes, so looking at sucrose excretion and the famous lactulose-ramenose ratio as a way of seeing if there's changes in the larger sugar molecules getting across the gut wall. So when the athletes were asked to run in a no fluid state, you can see that the permeability, if you like, is dramatically and significantly increased compared to either a placebo or a glucose solution. What's interesting in this study is if you compare, say, plain water, placebo, to the glucose solution, this suggests that with any type of fluid, to an extent, so long as it's not heavily concentrated, that this might influence or reduce or attenuate some of the gut hyperperfusion we've seen in previous studies. And it might also be linked to reducing some of the hypothermia that's experienced inside the gut. So clearly, exercising in a hydrated state could be a very important factor for many people. Sounds obvious, but you'll be surprised. Years and years ago, I did a study where we looked at just looking at simple hydration measures in runners undertaking their evening training session. And we found that the majority of runners were turning up to their evening training session in a dehydrated or chronically dehydrated state. So you might be thinking, well, yes, I hydrate all the time. But for many runners, that's often one of the last things they think about prior to training, surprisingly. The other aspect of the literature that's often quoted is this term endotoxemia, this idea that as we start to cause damage to the gut, or if we have gut ischemia or reperfusion after exercise, that the gut sort of reacts, if you like, and that there's certain particles that are either able to get through the gut wall, or they're broken off from the bacteria in our gut, and they can also get through the gut wall and cause all sorts of issues. So for those of you who know the difference between the types of bacteria in the gut, you know you've got gram-negative and gram-positive. Well, the gram-negative bacteria have a particle on it called lipopolysaccharides, which can get broken off when they're under states of hypoxia or ischemia, and those LPS particles can get through the gut wall. And this endotoxin release, if you like, from the gut can start to influence not only the tight junctions that are between that are involved in the structure of the gut, but they can also lead to what we call a cascade effect, where you start to get these inflammatory cytokines that are leading to inflammation elsewhere downstream. Now, that could be related to why people experience things like abdominal cramping, abdominal angina, nausea, and vomiting, as an example. When we start talking about raising the temperature of the gut, the top right of this slide is a lovely slide by Lambert, which demonstrates what happens in a controlled rat. And you can see from the top right slide, the left-hand part of that is a very nice gut in a gut lining where you've got a lovely villi, all nice and even. As soon as the rat is heat stressed to near 40 degrees, you can see there's massive destruction of the villi. So you can sort of see these tight junctions between the villi start to open up, and you get this kind of permeability-like effect, which allows other particles, including allergens, to get through the gut wall. There's also, you can create what's called a sodium-potassium pump damage on the basolateral membrane, and that could lead to what we call reduced fluid absorption and, more importantly, reverse fluid accumulation. And this might explain why some people get diarrhea if it's not associated with things like drinking too much coffee before they go for a run, which leads to increased motility. So there could be various factors at play here which are physiological, but whenever I'm working with someone, the very first thing I look for is, what's the patient story? Because often in my experience, it's actually something very simple they've not done prior to training, or they're not doing in their training. Having said that, though, if I just think back to my own experiences, again, there's a few of you in the audience who do know me, and you'll know my background when it comes to things like Ironman triathlon. I've actually experienced what I perceive to be full-blown endotoxemia. And in ultra-endurance sport, there are lots of papers reporting this. One of the most famous ones was a study done by Brockant in 1988, looking at athletes undertaking the famous Comrades Marathon in South Africa. And what's interesting about this study, even though you've really got to go back to black and white text here, here's the actual original picture from that paper, where they looked at measuring plasma LPS, this endotoxin particle. And you can see that those people that took a longer time to complete the race, greater than 8 hours, and I'll probably get Ian to talk a little bit about Comrades afterwards, because he's probably had an experience of doing it, I'm not sure. But you can sort of see that those people that seem to take longer, so it's not the intensity, the duration in this case, had higher levels of LPS. I should also mention that of those that reported as endotoxemic, 80% of those reported various symptoms such as nausea, diarrhea, and vomiting. And what's also interesting is it took anywhere between 1 week and 3 weeks after the race to actually recover from that, which is quite interesting. I should also mention that the LPS values on this slide are more in line with what you would see in clinical sepsis. So this is very severe levels we're seeing. Even though it looks very small on your slide, these are classified as very high levels. In contrast, this is another paper by Professor Yerkendrop in 2000, looking at athletes, good, well-trained athletes undertaking an Ironman triathlon. And what they saw in this study was a sort of what I call a very mild increase, even though it's significant, a mild increase in LPS values using different units after the event, so 1 to 2 hours after the event. But notice there's this kind of secondary increase at 16 hours after the event. And this might explain why some people feel very ill at the end of an Ironman, but then some don't, and then the next day they feel ill. It's possibly related to some of the changes in the inflammatory markers, because in this particular study, even though they didn't see an increase in C-reactive protein after exercise, they saw it the next day, 16 hours after exercise. So some people will probably abandon the race because they're seeing this change in the gut. Other people might finish the race and then react the next day or even the day after. So how do we put this into some sort of model? I'm very conscious of time, so I'll crack on. This is a lovely paper, if you've got time to read it, by Costa. He's done a couple of papers around this area where he puts together a lovely model that kind of gets you thinking a little bit from whether the issue is coming from a gastrointestinal circulatory perspective or a gut-brain perspective. And I won't go through the whole slide, but you can kind of see how the physiological patterns unfold. But in terms of the science, there's one area that kind of frustrates me a little bit. And if I just highlight the ones on the slide that I've done in red, we've now got reasonably good evidence. So anything with a plus or a 2+ next to it suggests that we've got reasonably good evidence that these will have a positive impact on some of these pathways. But notice there's quite a few where we still don't know an awful lot from a kind of collective science perspective. And yet, on an individual patient perspective, we might try certain aspects. So things like probiotics or curcumin or maybe various gut training strategies, or even looking at challenging the diet in terms of a gluten-free or low FODMAP perspective. So when I look at this, what I see is kind of there is a real need to understand this area more, but also to have more science, more research undertaken on these various potential strategies. And also to understand why one person might respond in a certain way and another might respond in a completely different way to the same strategy. Okay, so at that point there, I just want to pause and just ask Ian, do you have any questions that you have for me at all? Oh, can't hear you. Don't worry, shall I carry on? No, I can't hear you, sorry. Don't worry, I'll carry on. We'll pick it up at the end, hopefully. Okay, so just to pick up on this, thinking about what athletes might do in the case of a race. Again, I'm just throwing lots of papers at you on purpose, just to get you thinking about, some of the science that's out there, some of the literature, and of course, from your perspective, if you want to delve into these studies a bit more or these papers, then the references are at the bottom. But here we've got a lovely paper that was also done in an ultra endurance marathon, where they looked at what commonly is undertaken by race finishers and non-finishers of an ultra endurance marathon. It was quite interesting to note that if you look at, for example, the fluid intake, notice that the finishers tend to drink more, they tend to eat a little bit more protein, they tend to eat more sodium or consume more sodium. So the ones with the stars next to them down the bottom of that table represent significant differences. So kind of the very broad advice that's often quoted in the literature is that athletes should avoid or be avoiding protein, fat, fiber, and milk products, which can aggravate GI symptoms during exercise. And yet, here we've got some data that shows that, to an extent, trained athletes who finish races tend to eat a little bit more protein, maybe a little bit more fat, you could argue, and this is ratio per kilo. And it's interesting, when we've interviewed long distance ultra athletes, often they quote that they drink milk and eat solid products which are high in fiber. So it's interesting that we see statements like this, and yet it's almost in contradictory terms to what athletes tend to do. But if an athlete were experiencing symptoms, then maybe taking out 1 or 2 items during a race might be one strategy moving forward. Then we've got the whole concept of gut training. So there are various strategies that have been proposed in the literature. Again, thinking about time, I'll just whip through these, but thinking about training with relatively large volumes of fluid, which might be contradictory to your kind of thoughts, but often this is a gradual way of increasing the gut distensibility. There's a whole host of recommendations that are often thrown in the literature by Costa, which are very useful to go through. But what you're trying to do with a gut training perspective is either increasing the type of fuel that you're using at high rates, or improving the gastric emptying perspective. So in other words, getting the fluid and the food directly into the gut and directly across the gut wall. So if you can increase that gastric emptying rate, and you can improve your tolerance to stomach distension, then you should be able to consume more and perform at a higher level. There's also a lot of evidence suggesting that if you have a liquid meal, either before or during exercise, that this can actually attenuate some of the perfusion, the hyperperfusion that is often reported. And it can also lead to a state of increased exercise comfort, especially if you're doing a long distance event. And to put that into perspective, of the very few studies that have actually investigated this, here is one, which was undertaken by Cox in 2010, where they fed athletes a high carbohydrate diet. And just to put this into perspective, 8.5 grams of carbohydrate per kilo is just about on the recommendations for ultra endurance, but it's a lot of carbohydrate. Just trust me on that one. It's a lot of carbohydrate to eat in a day. But by training the gut, what they found is not only could the athletes actually ingest more carbohydrate during exercise, but also this translated to increased activity of citrate synthase. In other words, they were able to use their fuel significantly greater during the exercise test. And also, just to kind of take that to the extreme end of the scale, we've done some work working with an athlete who broke the world Ironman record. And this is actually their data from our lab in going back to 2012. And to put this into context, we actually trialed this kind of gut training perspective, where we were trying to get them eating specific foods and specific products at a higher quantity going into their event and throughout their event, which led to not only a higher, what we call exogenous oxidation rate, in other words, they were able to make more use of their drinks and their gels, but they were still able to maintain a really high rate of fat burning during their exercise. And then the net result is they could sustain a much higher power output for longer. So this gut training perspective could be useful. Having said that, if someone has direct issues with nausea and vomiting, where it's very prevalent and it often occurs, in contradictory to my statement around when nausea comes on, eat something. If someone is actually being sick, there's also the strategy of just simply not eating or having a gut rest during exercise. Okay, so I'm just conscious of time. I just want to whip through a couple more slides, and then we'll just we'll turn it to the Q&A and maybe come back to the slides that I've got left. But in terms of certain strategies from a nutrition perspective, we've got loads of ideas in the literature ranging from prebiotics, probiotics, glutamine, colostrum. There's even evidence of zinc carnosine influencing the gut wall, various flavonoids including curcumin, and various other strategies including low residue or low FODMAP diets, which I might get onto. But if I just spend the next couple of slides focusing on probiotics, there are various papers that do hint, and I'll say that word carefully, they do hint that probiotics could have an effect. The challenge with probiotics is often you see a very individualized response, as I'll show you in a second. And it may be that we should be looking more towards a prebiotic diet as a kind of a strategy in the background, if you like. But here's one study where the authors gave the participants 14 weeks of a particular probiotic strain, and then looked at a particular protein, zonulin, which is often involved with the tight junction proteins in the gut, in the stool before and after 14 weeks of treatment. So the black bars there demonstrate a reduction in zonulin in the stool, which suggests that the probiotic might be creating some sort of resistance in the gut and some sort of biofilm protection. So when we think about probiotics, that could be important. Think about the time course there, 14 weeks, and think about whether other factors such as a prebiotic strategy involving foods like onions, bananas, oats, etc., could also have a beneficial role to play. So we've done some research as well on probiotics. I published a paper in 2016 based on our experience of working with a very, very nice group of individuals who were very lovely to me, and they were the first participants to undertake a study where we were interested in the kind of question was, can anyone run an Ironman? So we had these guys, we were working with them for, I think it was about 9 months, doing a nice big long training program. We could look at their diet, which is highly variable, by the way. But in the final 12 weeks of the study, we had our athletes either taking this particular product, which is by BioCare, not that I'm promoting them, but it was bioacidophilus 40 with or without an antioxidant, or a placebo. And we were interested to find out whether this had any impact on endotoxin units and hence endotoxemia leading up to the race and after the race. So what we found, if I just jump to the results, this was the probiotic and with antioxidants and the probiotic group. And what we're looking for is a definitive reduction in the endotoxin units from baseline to pre-race. And the pre-race was a few days before they left to go to the race. And then we managed to capture some data about 6 days after the race. And in both cases, the probiotics showed a significant reduction in endotoxin units, very similar to the values you saw earlier on with the Yerkendrop paper. In contrast, the placebo group didn't see a significant reduction. And in fact, when we looked at the gut permeability using a lactulose sugar probe, the only group that increased throughout the study was the placebo group. So we saw this kind of continued disruption to the gut with placebo and a blunting effect on the permeability with the probiotic groups. Interestingly enough, what was interesting from my perspective is looking at the range between people. So some people had very, very mild symptoms and very low levels of endotoxin units. Other individuals had what I would call still mild, but going into that moderate domain of endotoxin units leading to more severe symptoms. But there was a significant reduction in GI symptom count and severity during training. If I just jump to the race times, these were the results from our study. So if you look at the overall race time for an Ironman, I've done it in minutes just to keep it consistent. Now, the results were not significant because there was such a diversity between these individuals. But it's very interesting to note, and this has been reported in several other studies, that with both probiotics, notice that the swim was faster, the cycle, particularly with the probiotic only, was faster, and the run stage was faster, but it wasn't statistically significant. But if you said to me, well, okay, if you look at the times at the bottom there, those on the probiotics were running roughly about an hour faster than the placebo group, that's quite profound, even though it's not statistically significant. So it's worth just thinking about the difference between physiological significance and statistical significance. And then finally, I just mentioned one of my colleagues, Jamie Pugh. He's published a lovely paper in 2019 looking at a similar approach, but a 28-day probiotic strategy for recreational runners going into a marathon. And what he demonstrated here is that the number of upper and lower and total GI scores were significantly lower, particularly as we go through that latter phase of the training in the probiotic group compared to the placebo group. And my understanding is this was the same product that we were using as well. And indeed, if you look at their results from their race strategy, this is the lactulose-ramenose ratio. So you can sort of see that if those taking the probiotics, there was a difference after the race in both groups. If we look at the relative speed, there was a significant difference between, even though the race times were similar, notice that the relative speed was different between the two groups at the end of the marathon. And if we look at the symptom score during the race, notice that those on probiotics had a markedly blunted response compared to the placebo during the race itself. So I could go on all day. I'm very passionate about this area. I love doing research around this area, but I think I'll just pause there and hopefully we can hear from Ian. I still can't hear you, Ian. Ah, there you go.
Okay, try unplug the fancy mic. All right. Thanks, Justin. Do you want to quickly unshare, and then I'll put up my slides so, just for a couple of minutes, and then we'll get on to questions. So let me put these up. So everyone, if you've got questions, Justin stimulated, start typing away, and then we'll get on to those in a second. I've already got a couple of questions for you, Justin, as well. Before we do that, I just wanted to bring to your attention that we're starting our next intake of the Certificate of Integrative Sports Nutrition on the 1st of October. So we're busy getting ready for that, creating all new video material, so completely refreshed course this year. This is the course page we've just created a new website, thanks to our IT guy. So go and have a browse and just learn more about it. It's a 3-modular course. The first one's functional / integrative health within nutrition, which is basically the whole ethos I've been trying to work into sports nutrition for the last 15 years. The second one is performance-based nutrition, but with a healthy dose of application and integration and personalization as we do. And then the third one is specialized nutrition topics, which we've asked Justin to do one of those talks as well. So our pricing, there's the website details. So if you just go into sportsnutrition.com, it's under courses, you'll find that. The price is, the full certificate costs $2,300. We've also got a sports cookery course, which you can do a combined or you can do it on its own. But we're still within the early bird phase. So these are the prices. So it's $2,100 for the certificate, or $2,600 if you do it with the cookery as well. That's Friday. Okay, so the end of Friday, you get that price. If you're with band or bases, you'll get 10% off that price. If you're a student, you'll get 20% off that price. So being a Scotsman, I look for value for money, and I haven't increased the prices for 3 years now. So hopefully that's what we're achieving. Okay, and then there's all the contact information. But as Justin said, we'll share all the slides, these ones and Justin's slides tomorrow with any relevant links and stuff. Okay, right. So Justin, we have Maria. What do you expect to happen with HIT regarding the damage to the gut wall and effective dehydration? So high intensity interval training.
Yeah, thanks, Maria. It's kind of a two-edged sword, that, because it depends whether the person's dehydrated before they start, or are we looking at the effect of HIT directly. There are some papers on this. There are some mixed papers on this, actually. There are some papers that have demonstrated no effects of HIT training on gut because of the type of intervals they were doing. Equally so, in unaccustomed individuals, there have been reports of more accelerated gut dysfunction. Typically, I think, because of the way they're shunting blood away from the gut. So I can't really answer whether it would be more prevalent because we just don't have enough studies on this area yet. And as a researcher myself, I'm always keen to look for collaborative researchers out there. So this is one area we're actually interested in looking at, funny enough. So thanks for asking that one. But I would expect someone who's unaccustomed to maybe, who's got a previous history of gut issues, or maybe has maybe not the best diet in the world, maybe a poor quality diet, doesn't eat too much whole food nutrition, maybe doesn't have a diverse intake of foods, might actually respond differently to someone who's got more diversity, particularly if it's affecting the gut biome as well.
Can I throw in a comment just as I was thinking there? Just in general, physiologically, we've got an impact of intensity and duration and how they interplay. So if you get somebody, let's say, quite intensive sport over a prolonged period, like rowing, somebody going out rowing hard for an hour, physiologically, like neurologically, endocrinologically, immunologically, they're all impacted potentially in a negative way with that combination of the two. So presumably there's a combination factor there. And if somebody does a comrades marathon, which is prolonged, but they manage to balance the intensity and they're feeding well, they can get by without too much impact. But yeah, some rookie HIT trainer could go in there guns a-blazing and in 45 minutes create some quite strong cytokine response, I would imagine.
Yeah, absolutely. And just to add to that, you know, when you start looking at relative exercise intensity, so even if we had the same absolute intensity kind of for each person in the field, let's just say you've got someone with a fairly low capacity and someone with a fairly high oxygen capacity, so VO2 max. For them, it might, someone who's less trained, their perception of that moderate exercise might be much more severe than someone who's well trained. So this is probably explains why someone who's more trained you'll probably see a dampened response or a less vicious response with someone who's well trained compared to someone who's less trained, especially if the exercise is quite unaccustomed. And there's another factor to layer in here, which is exercise duration. Unless you maintain that kind of nutritional program, that hydration strategy, that electrolyte strategy, etc. And again, just thinking back to my experiences, not only when I was trained, but also now when I'm not so trained, if you're cycling or running for 2, 3, 4, 5, 6 hours, when you start to get beyond that saturation point of the gut, your natural tendency is to stop wanting to eat and stop wanting to drink. And that could be where you're aggravating this response the most.
Thanks, Justin. We've got a question from Catherine. So Catherine herself is very well trained in the gut area, and she lectures for us on module 1. So her question is, how reliable do you think zonulin in stool is as a marker? Also, I was really interested in your low FODMAP study and GI dysfunction. Could you talk a little bit more about the study? And clinically, have you found a greater association of this benefiting athletes with underlying SIBO, IMO, dysbiosis, etc., and addressing this to help race issues?
Hi, Catherine. Nice to hear from you, and fantastic question. PhD level, I would say that is. So Okay, so to start with the first one, how reliable do I think zonulin is as a marker? If I'm being absolutely honest with you, I would say not very. And there's a strong reason. There have been several papers that have looked at the reliability and validity of zonulin in stool recovery. So, and also there have been some criticisms in the literature around whether zonulin, are you actually measuring zonulin in the assay kit? It's a bit like we talk about LPS, lipopolysaccharides, but what you actually measure in the assay is endotoxin units. So thinking about the terminology and also some of the reliability issues, we chose in one of our studies, what we were talking about recently, not to use zonulin as a marker because of the reliability issues, which then begs the question, what else can you measure? And this is why a lot of big researchers, a lot of research groups are going down the road of looking at the biome diversity and specific pathology of the gut now. But you can look at other tight junctions as well that have been mentioned. Thank you for mentioning the FODMAP study. For those that don't know about this, it's on my slides at the very end. We had one of my postgraduates looked at, I was very interested in FODMAP. For those that have not heard of FODMAPs, I don't know if you can still see my slides, but don't worry if you can't. So this is where you've got fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, or FODMAPs, which are short chain carbohydrates. Let me just come off that and also that, so I can see you again. So we did a study. It was a very short study, but we wanted to find out whether giving general runners who have experienced some sort of gut issue a low FODMAP program for a very short period of time, and there's a reason for that, whether it benefited them in terms of gut symptom severity and training quality. And what we actually found was there was a definitive reduction in gut symptoms by following a low FODMAP diet compared to a high FODMAP diet. We found that training quality was improved, but on a negative, we found that the athletes dramatically changed their diet as a result. And we're only talking about a short window here, and they lost weight. So you could argue that on the one hand, it might be benefiting them from a severity or symptom pathology perspective, but on the other hand, one of the questions we had is if you held this for a longer period of time, and we're talking 2 to 4 weeks, by the way, that could have negative implications for them in the longer term if they're losing weight dramatically because of the choices of foods they're having. So we did see some benefits. We didn't measure dysbiosis, and it was one of the things we wanted to, but we measured it indirectly through some of their symptom perceptions. I would be a little bit more cautious with FODMAPs because of the type of foods that are often recommended and the sudden disruption to the diet. But in acute cases under clinical supervision, it could be quite useful for certain people.
I think that was an excellent response, Justin, because FODMAP's one of the sort of dietary diet types that a lot of people now know about, and then they try and do things themselves, but can imbalance an otherwise healthy dietary approach. So yeah, I think supervision short term is important, and understand what you're trying to do with it is the key to that clinically. Can I throw you one question? I don't think you've done comrades yourself. I'll just comment on that. I never did comrades. In my racing day, 5 minutes was, all my races were under 5 minutes. So to do something over 6 to 8 hours, no, that's a bit too far. But I definitely lost count of fingers and toes of the clients I worked with who did that, because it was a massive, massive event in South Africa. And yeah, I think you used the word earlier, and that's personalization. Personalization is really, really key to working with people and understanding what makes one person tick and another not. And I would say that most common thing is bad quality sports drinks and gels being overconsumed in long distance events. And then, then they're in my clinic room. I didn't make it past 60 Ks. Can you help me next year, please? But I was going to ask you, Justin, from a personal perspective of a lot of observations scientifically, you've done client observation and you've had your own journey with endurance sport. What would you do for, say, a morning breakfast nowadays before you did an ultra marathon run or an Ironman?
Yeah, great question. I mean, one of the things I try to do, and I wouldn't say I'm perfect at it by any stretch of the imagination, is I try to take the science and translate it into practice at some level. So it's my first answer to that is, you know, number one, if it's an actual event, don't try and change anything on the day. Again, I've seen this so many times where people have rocked up to an event and suddenly they've gone and done something very different to what their body is used to, and they wonder why they've reacted to it. And not just the day of the race, but the day before and the day before that as well. So I think consistency is key. I think number two is, if you haven't practiced with a high protein or even a high fat approach, we could have a separate discussion around high fat diets, but I would keep it something that's easily manageable, something you're used to, but also easily digestible. So the classic one would be something like porridge with fruit, for example, that you give your body a chance to digest it. But I think more than that, I think normally what I would have done, and certainly I will be doing in the future as well, is looking at hydration going into an event. So a lot of athletes will what we call drip feed their fluid intake and even electrolyte intake going up to the start line, so that they're maximizing their hydration to an extent before they actually start really dehydrating. So it's a kind of a combination of easily digestible foods, a combination of polyphenols with carbohydrates and electrolytes and fluid. Notice I didn't say caffeine there, by the way.
That can be, there's a few other topics here, Justin, if you want to come back, you'd be more than welcome. So the fat carb discussion, the caffeine discussion. A little tip I did with my clients was just to get a plastic water bottle that they fill up with, I would tell them make DIY sports drinks to keep them off the synthetic stuff, and then just drip feed it in the hour waiting to get in the water or on the start line. And then there's generally bins around that can chuck it away.
Yeah, and again, I don't know if this is relevant, but one of the biggest questions I get asked when I do talks is, so what should I actually, you know, which sports drink should I, which brand should I drink, which brand should I eat, or gels or whatever. So my response is whatever's worked for you. What do you prefer? Because I've had people that have done everything differently. So they've eaten the classic gels, the classic brands, they've tried different brands, then they've gone to natural foods and they've got very different responses with natural foods compared to synthetic foods. I've had other people that have used variety in their patterns. That's what I do. I use a lot of different variety in my feeding. Then I've had other people that have just done the whole thing on jelly babies. So, you know, the point is to look at what the food's actually trying to do for you and whether you're actually, it's working for you. If it's not working for you, change the strategy.
Yeah, Debbie's just added in a South African strategy of gel on toast. So there you go. You see anything in South Africa?
I've seen pizzas in an Ironman.
So is this healthy thin crust Italian pizza? Justin, thank you very much. It's been an absolute pleasure having you on, and I hope we have more chances to get together again.
Thank you.
Take care, and we'll be in touch very soon. And thanks for everyone for joining tonight.